Good evening, everyone. Welcome to this evening's meeting of the Health and Social Care Review Group. Just to remind everyone, there's a few admin things to go through. The meeting this evening will be live streamed to the public. If there are any exempt private items on the agenda, the live stream will cease and the meeting will move into private. A recording of the meeting will be available on the Council's website within 24 hours of the meeting. Would members and officers please remember to switch microphones on when speaking and speak directly into the microphone and switch microphones off when finished. If reporting officers joining using Teams can use the hands up icon for any questions or comments that you want to make. Please turn your camera and microphone on when speaking and off when finished. Please switch mobile phones off or place on silent mode. Apologies for absence.
We have apologies from Councillors Agbley and Councillor Petts.
Thank you. Minutes of the last meeting, 16th of August 2022. Are those okay? Thank you. Any disclosures of interest? Nope. Any urgent business? I'm not aware of any urgent business.
None, Chair.
References from committees and other bodies?
None, Chair.
Okay. Chair's update. There's just one issue that I need to report on. Since the last meeting, I've spoken to the Chief Primary Care Officer and the Chief Executive of Luton Health Watch, specifically about potential delays in patients leaving the L&D because of delays in fulfilling their prescriptions from the hospital's pharmacy. My understanding is that someone at the L&D is looking into this to try to see if it is a systematic problem. It's obviously concerning for the patients involved, and also could have a wider impact on issues like bed blocking. My understanding, hopefully, that we will have something to report on that in the next meeting. That's me. So I think the first item is we have a change of order, so that the first item we're taking today is item 10, the Joint Strategic Needs Assessment, an update from Sally, I believe.
Yes, thank you, Chair. So this paper is a regular update to the board. I think the agreement is that it comes annually, and in the last year we've done a lot of work on our Joint Strategic Needs Assessment and how we're presenting the data. So just as a reminder, the Joint Strategic Needs Assessment is a statutory requirement between Council and working with health colleagues to lay out the data around the population and the needs in an area. So we've got two documents now in this new refreshed version that we have. One is recording This is Luton, which lays out all of the demographics in Luton, and the idea is that it has all of the key demographic data in one place as a source of information for people when commissioning services or making decisions or reviewing the population in Luton for health or care needs or other services. And then the other document is more specifically around health and care needs in Luton and lays out against various indicators how we're doing compared to national, region or some similar boroughs. So the paper has both documents, I think, or the link to both laid out in it. So it was just to share that and take any questions. We also have a newly refreshed, what we're calling Intelligence Observatory, which is one of our web pages within the council, where you can access all this data now. And when we do deep dives into specific topics, that will be put up there as well. So we've got a much clearer repository of some of this information.
Thank you, Sally. Any Any questions? Okay. I have a couple of questions. I think you were talking about resourcing and limited resources. How has that affected the work you've been doing and the development of the JSNA?
Yes, so it's regarding, I think what I meant by that was that the JSNA is kind of how long is a piece of string. So we could do so much analysis and work that it could be, 3 people's full-time job over the course of a year. So we've tried to make a much more systematic and streamlined approach to it. So we've got the right data that we need in one place, and then we focus on key deep dives within the year. So 3 or 4 deep dive needs assessments. Previously, it was a really, really big, weighty document that took a really long time to write and tried to cover all the different specific issues across the borough. So you'd have a whole big long chapter around children's obesity and a whole chapter around education and make sure it covered absolutely everything. Whereas what we're trying to do here is have the really headline important points within the sort of core documents, summary documents, and then do deep dives within the year on different areas as they arise in terms of commissioning needs or priorities across the course of the year. And we'll have a JSNA steering group that helps prioritise those requests or work through what we need to be focusing on within the year. And then we'll also need to refresh those key headline documents annually as well. But it just means that I think it's a more efficient way of doing it, because previously it took so long to create such a detailed document, and it was never quite clear how exactly it was getting used. So hopefully this is a better way of doing it. But we will take, which is the purpose of it coming here, we can take feedback and comments on it as it progresses and whether this is useful for people.
Okay, thank you. Yeah, I think it certainly is a useful process to go through, and obviously a lot of hard work's gone into it by yourself and by the business intelligence team. So yeah, thanks for that. Is there any more comments or questions? Okay, thank you.
Thank you. And I did say apologies thank you for changing the agenda around. So I will stay on for a little bit, but I will have to go quite soon. So thank you.
Oh, no problem. Thank you. Okay, so I think we're now going on to item number 7. Developments of local specialist child and adolescent mental health inpatient services. And who is... Someone's waving their hand.
Good evening, Chair. Yeah, Jo Meehan. I'm the Associate Director for CAMS across Bedfordshire and Luton with East London Foundation Trust. And I'm joined by my colleague, Robin.
Hello, Chair and colleagues. Robin Campbell, I'm the Deputy Director of Integrated Care at ELFT.
Thanks very much for inviting us along this evening. I believe a paper was circulated earlier outlining the developments of our Tier 4 provision. So I'm very happy to talk to that. I haven't done a presentation, but just to pull out some of the key themes really of the developments to date, and then I'd be very happy to take any questions thereafter if there were. As some of you may be aware already, our CAMS inpatient unit is well underway. Our young people have named it Evergreen. The location is sited next to the L&D, the Luton and Dunstable Hospital. It's an 8-bedded interim unit, which will serve young people from the ages of 13 to 17, because they're generally the age group that we tend to admit across Beds, Luton and Milton Keynes. Plans are well underway. We're 90% into our recruitment. We've been working really closely with our stakeholders, partners. Everything we do is co-produced, so our young people are very, very much at the centre of all the work that we've been doing. We 90% underway with recruitment. Young people have been involved in the recruitment plans. We'd hope to be going live beginning of December. That has been delayed somewhat because we've had some difficulty recruiting into some of the key posts, for example, the psychiatry. But we're really clear about the clinical model, the clinical design. We've been linked in with the regional collaborative to think about how that would work across the wider region. We've got great relationships, as I say, with our key stakeholders. We've been having regular stakeholder meetings with our education provision. So we've got a really clear education plan that will serve the interim unit, the 8-bedded unit. And we've been thinking clearly with our young people and parents, carers. Every fortnight we have stakeholder events with them to think about the clinical model and the ethos of the unit. The main ethos of the unit is all about hope and recovery, because we want to keep those inpatient admissions as brief as possible. So a big part of the work we've been looking at is our 8-bedded inpatient unit, but also what we call our admission avoidance pathways. And we see it as a bit of a jigsaw. So there's lots of work going on our community teams to strengthen and develop the community teams in how we respond to crises, how we prevent crises escalating, how we can support young people as safely as we can using robust assertive outreach measures, keeping their care as close as possible to home, keeping them at home to try to prevent that inpatient admission. There are times when inpatient admissions are necessary, and where they are, we'd like to try and keep them as brief as possible. So again, we're working closely with our community colleagues to see what we can do to bring those young people out of inpatient safely back into the home, early discharge. We know there's a demand at any given time for about 18 young people across Beds, Luton and Milton Keynes for an inpatient unit admission. We work really closely with the collaborative to see how we can track and monitor those young people that are currently sitting in other areas across the region. As we know, young people have to travel miles and miles away for those inpatient admissions. We don't tend to have a local oversight of where they are or those lengths of stays. So we've developed a system where I think we're much more confident about how we manage those admissions. We're really working closely with the collaborative to think about the clinical prioritisation of cases that do need inpatient admission across the whole region. And what we can start to do is think about how we can repatriate those young patients who currently are sitting in inpatient provisions when our Evergreen unit becomes live in December. That's a really high, broad overview of the model, the ethos, and where we're up to date with the developments. I don't know, Robin, if you wanted to come in and talk about the finance, or if anyone has any questions based on the paper that was submitted.
Yeah, happy just to add to that. Thanks, Jo. Firstly, to say that the ward has been described as a sort of interim unit, but it is very much a kind of a long-term permanent fixture for Bedfordshire, Luton and Milton Keynes residents, very much addressing a gap in provision for our children and young people for inpatient care. And it's called an interim unit very much because it's initially 8 beds, but we very much see the requirement going up to 12 beds for general adolescent and 6 beds for PQ, which is intensive care unit for children. And our kind of long-term plan for that expansion is being wrapped up in the Bedford Health Village development, for which we'll be bringing a further update back to this group, I think next month. So although it's called interim, it's very much a sort of staging post for an expanded unit that will provide the kind of long-term, address the long-term needs sustainably for children and young people across the system. Just a very, very quick update on the finances. And just so we're extremely grateful and fortunate to have been awarded capital funding to get this project off the ground by both NHS England nationally as part of what's termed the medium-term funding to address this gap, as I said. And we've also had a top-up of funding to address some of the inflationary cost pressures that we've experienced, or everyone's experiencing at the moment, via our East of England regional urgent and emergency care funding. So that's addressed the remaining gap that we had. We've got revenue funding from our medium-term bid for the next 2 years up until the end of 23-24 thereafter, we're working with our East of England collaborative colleagues to continue the funding. They essentially hold what's called the specialist commissioning funding for the CAMS inpatient beds across the region. Previously, it was held centrally by NHS England. It's now been devolved to collaboratives, so they will be picking up the funding after 23-24, and we're working through the arrangements for the Bedford Health Village expansion of the beds that will require that funding going forward. So all in all, really good news, and good to be able to report that excellent development. Thank you.
Thank you. Does anyone have any questions?
This board you have, formed the board. Who else is, apart from young people, attend this board meetings, and how often they have?
So I can take that one if you want, Robin and Chair. So we have weekly mobilisation meetings, which include all of our partners from the local authority across BLMK. We have separate meetings with our education leads. They're fortnightly. So we're really working, although we're working with our education leads across all 4 of the local authority education provisions, we're working really closely with Luton Education, because it would be those that will be providing the services in there. And then every fortnight, we have a meeting with young people, and then we have a separate meeting with their parents, carers, as well as. So there are several meetings, lots of conversations going on, but I think it's been worth it. It's been needed, and that's been in place now for about 8 months since we were awarded the funds.
Okay, one more question. As we had previously problems with the CAMS and the input from the CAMS in regard to children's services in Luton. How is the position now, and what resources do you have put to overcome this issue?
Can I just ask a little bit more about the issues that you had within CAMS, just to give us a bit of context?
3-4 years ago, the Ofsted report was not very good on CAMS input.
For the community CAMS and how we contribute to. Yes,
and the waiting list is quite high.
Yeah, and that would have echoed where we were 3-4 years ago. We've had huge amounts of investment into community CAMS, which is separate to our Tier 4 offer, although they're very closely linked, because everything that needs to go on our Tier 4 offer must dovetail with our community pathways. So we've been really fortunate to really develop our community offer. We work really closely with our colleagues across the partnership. We're really keen to walk towards Luton becoming a Marmot town. We've strengthened our clinical offer. We've increased our recruitment, but under no illusion, we're still under great demand. Young people are presenting with far more levels of acuity than previously noted. The referrals have gone through the roof, particularly for Luton, and particularly for young people presenting in crisis. And that's been the picture for the last probably 18 months. So we're seeing more and more young people that would present with higher level of need than we've ever seen before. And these young people would generally present to A&E. But I feel fairly confident that we have strengthened a lot of our clinical pathways. We've introduced a single point of access, and we do that in partnership with our colleagues, early help colleagues, our Tier 2 providers, CHUMS. We've also taken on the contract to subcontract our Tier 2 services with CHUMS. Previously, it was subcontracted differently. So I think that helps us think about the model that we want within our local neighbourhoods, but across the wider system. So there is much more opportunity to work closer with our partners across the partnership. We've got growth in schools. I'm thinking about the mental health schools team. So there's lots more provision going into schools. There's lots more provision going into GP, local surgeries. So we're trying to capture young people at that earlier need. to try to shift the balance from them later on presenting in crisis. So there's lots of work that's gone on underway to try to reduce the waiting times despite the growth in demand. And I'm pleased we had a fairly positive SEND inspection, which highlighted where we were in terms of our joint working. And I know we're due a re-SEND inspection as well. So.
And just to add to that, I think it goes without saying, oh, sorry, Chair. Just to add to that, I think it goes without saying that children and young people remains an absolute priority in the NHS long-term plan. So, part of our programme is really heavily influenced by all the work around children and young peoples, and will remain so as the plans are developed over the next few months coming into the following financial year. And we're expecting further announcements from the centre from NHS England in the autumn time.
I want to ask you about the SEND report, when that was actually presented.
I wouldn't know the exact date of that. I'm sure my other colleagues in the local authority may know better, but I can certainly go away and ask them.
Perhaps if you could provide the next time a report from the SEND to this meeting.
I'm not sure I'd be the best person to do that, but I can certainly take that back to the local authority and see if someone's willing to give an overview on the SEND inspection.
Thank you.
Yeah, I've got a couple of questions. You're talking about the admission avoidance pathways. Is there a temptation to use that because there's a great demand for the inpatient services? Is there a temptation that you use the admission avoidance pathways as a way of cutting down on that rather than as necessary? Is that?
No, I mean, safety is always first for us. It's a fine balance, really. The last thing we want to do is admit young people into inpatient provisions, because the trajectory thereafter isn't great. You know, we want to do everything we can clinically to support them safely at home. So we've been really creative in how we can put that wraparound support. We're working really closely with our colleagues in the local authority, for example, to make sure we can put in packages of care to keep that child as close to home or within their own home. But it's got to be safety first. So if the risks are increased too much, then we'd be going down the inpatient admission route.
Okay, thank you. The other question is about the finance. Just to clarify that, for the development of the 18-bed complex, is the funding for that available? Is that agreed, or is that dependent on something else? Paragraph 11, the trust has also been successful in bidding for additional capital funding. Is that for those 18 beds?
No, that's not. The additional capital funding was to address the gap that we had in the capital build due to inflationary cost pressures that everyone's experiencing at the moment in construction. The expansion of the ward to an 18-bedded unit would require further funding, and that's part of the overall development for Bedford Health Village. And we're looking at the options around that at the moment. You'll probably be familiar that a case for change was published, I think, last year, and we're currently working with partners to develop the next steps of that business case process, and we'll be providing an update on where that's going in, I think, the next meeting for this, which is next month in October.
Okay, thank you.
Chair, can I just mention about the question from Councillor Akbar on the SEND business? This is within the remit of the Children's Services Review Group and not this committee.
I meant about yes, that's the Children's Services remit, and they if we can ask to actually provide the next report whenever that they can be.
Okay, any more? Steve? Yeah. Councillor Moore.
Yeah, just on the permanent unit, obviously you mentioned about needing the additional funding. Is the long-term plan, and you might want to clear this up, as Robin's already mentioned, it's coming back to next meeting, you might be something to clear up then. Is the longer-term plan for that, once that permanent unit of 18 beds is up, would that then mean that the current interim setup you have at Luton, would that be a case that would then close down and things move to that permanent site?
Do you want me to answer initially, Joe, then you come in? So I think as part of the kind of full business case process, it's sort of, defined by, the 5 business case process and HM Treasury, etc. We'll need to be doing a kind of full evaluation of the options, both in terms of value for money and what's best for the residents of Bedfordshire, Luton and Milton Keynes. One of those options could include staying on that site, but it also may include looking at the Bedford Health Village site as well. I think at this stage, all kind of options are open, and that we'll need to consider that in due course. I think what's important is that, until we have secured the funding and the agreement from, NHS England and with local authority partners and the ICB, that sort of interim unit will remain there and is although it's interim, it's very much a permanent site and is built to what you'd expect of a permanent site, I suppose. And until there's any kind of alternative arrangement, that will remain there, that the ward will remain there. So I don't think there's any kind of issues of not funding or the business case process as we go into Bedford Health Village causing issues, if you like, for this interim unit. I don't think that would be an issue at all. Joe, I don't know if you've got anything to add on that.
No, perfect. Thank you, Robin.
That's right.
Thank you. I was actually going to ask the same thing as Councillor Moore, but I think I just wanted to make a comment. It's really good to see that this is going to be, it's sort of underway. And I think I'm really thankful that you have engaged the young people in the development process. It's been really good to see, because I think a lot of the time when we do things like this, make new buildings, we don't actually involve the people that it will be serving. So that was great. Thank you.
Yeah, just to second that about consulting with the young people. Yeah. Thank you, Joe and Robin. If there's no other questions or comments, yep. Thank you very much, and we look forward to hearing from you again. October.
Yeah, that's the general Bedford Health Village update that we'll be bringing back.
Yes.
For October. Yeah.
Okay. Thank you very much. Thanks.
Thank you.
Thanks very much, everyone.
Okay, so fortunately, item 8, the person reporting can't make it this evening. So
she's poorly.
Yes, the person reporting is ill, so can't make it this evening. So we're hoping that we can reschedule the cancer screening report for the October or the November meeting. So if we go on to item 9, East of England Ambulance Service NHS Trust Overview and Performance. Tom?
Thank you. Thanks for inviting me this evening. My name is Tom Abel. I'm Chief Executive of the Ambulance Service, and I'm joined by Dave Demera, who's one of our leading operations managers who works out of Luton. The update that I thought I would provide, and I'll hand over to Dave, is in a few parts. So we've submitted a report to you just to give you an update in terms of the performance and work that we're doing to improve the ambulance service for the people of Luton. But I think there's kind of 3 kind of important things to talk about. So the first of those is, as you are probably all very well aware, the ambulance service across the East of England has a fairly checkered history. And has been subject to fairly significant regulatory action over recent years. I'm pleased that we are making some progress in a number of those areas. So our most recent CQC report, which was published in July, said there'd been some marked progress in terms of some of the fairly significant cultural issues that we know that we've got within the organisation, and improved our rating from inadequate to requires improvement for well led, which is good. We've still got a lot of work we need to do, both to look at how we develop our culture, and so it is truly inclusive of all of our people, and creates an environment where if people are worried about anything or they are being subject to behaviours that are unacceptable, that they feel comfortable and able to raise those issues, and so they can be dealt with in a pragmatic way. And so, although we've taken some steps forward, we've still got a lot of work to do, and I've outlined some of the things that we are doing within the report, but also happy to discuss that when we get to questions. The second area is around response times to local people who need an ambulance. So Luton actually has relatively good handover times when you compare that to the regional performance and equally actually the national performance that you can see within the report. However, you will also see that we're still not hitting the standards that we would want. So we've been slightly above the C1 standard, so that's for the most life-threatening conditions. So I think it was 7 minutes 46 in August for Luton, and we want to get that in 7 minutes. And it was around half an hour for C2 patients, when we'd hope to try and achieve that within 18 minutes. Now, the factors for that are multifactorial. So there's definitely an element in terms of the work that we need to do around how we continue to recruit and retain people. We're working closely with our universities on that, but we're equally also looking at what we can do to create more flexible opportunities for people to stay within the service rather than choose to go and work in another part of the NHS or to work within the private sector, given that we know paramedics have a huge range of opportunities that they can pursue. The second area that we are working on is around handover delays at hospitals, and you'll have seen within the news that's nothing unique to this part of the world, but it is a challenge, and we're working very closely with our hospital colleagues to look at what we can do to both support them at the front door in A&E, where they have problems creating capacity for patients, and so they can be moved off the ambulance and into the A&E departments. But and secondly, also what we need to do and work collaboratively with the wider health and care system to help get people home once they're fit for discharge. Clearly, there's a lot of work still to be done. I know that the new health secretary was talking about that this afternoon, but we've got to continue to focus on that in terms of making sure that we can deliver good patient care. The third area too, I think, which is also really important, is what I think has become clear, and I don't know if Dave agrees with me or not, but is that 999 in the ambulance service has increasingly been seen as effectively a safety net service for people who can't access care or services through another route. And because we are here 24/7, and we do pick up the phone. So we are working to look at what we can do to, if we have people who call into one of our call 999 and are requesting support, what we can do if an ambulance isn't the right thing for them, but another aspect of healthcare or social care support might be appropriate, how we can actually refer them and plug them straight into that service there and then. So from November, we'll switch that on electronically. So that will mean that for, say, a patient who calls in who may be suitable for, say, a community falls team, actually what we'll do is we'll pass that patient to that community falls team to go and look after that patient. Or equally, a patient who maybe is in mental health crisis and actually needs support from a mental health community team, actually we can directly pass that call to that team, so they can respond to that patient appropriately and release our ambulances, so we can make sure that we can prioritise those for the people who need that service. We're also working to invest in developing a cadre of advanced paramedics. So these are paramedics with more advanced clinical skills to both work within our control rooms. And so actually we can better clinically assess people when they call in. That will help us signposting them and connecting them into the right service and making sure that we're prioritising the way that we dispatch ambulances. But secondly, also to look to get them out on the road. And so actually we can see and treat more people at home rather than necessarily having to take them into hospital, and therefore reducing the demand on hospital services. So we're in the process of recruiting around 60 at this moment in time. And we want to test that as we go through this winter. And if that's successful, that will definitely be something that we'll want to scale up as we look to the future. Because I think the future of our service is one where we have to work in partnership with other organisations in order to be successful. And that's very much something that we want to see and achieve. What I'll do now is I'll just hand over to Dave. So for those of you who don't know Dave and Joe, who another colleague who works out of Luton, became international celebrities, I think, for a video they attempted to is that the right word, Dave, to put out for International Paramedics Day. And I don't know, have we got the video? If that's okay to show.
Yeah. Yeah, can we take questions?
Yeah, if you want to take questions,
yeah,
and then we can
that.
that's absolutely fine. Yeah, how
thank
we like to.
Yeah. Okay, does anyone have any questions or comments or speaking?
Yeah, the one thing that wasn't on the report that I'd like to have seen, and you might not have been able to provide it, would be in terms of the handover times. We've seen a lot of stuff in the news. It's all come post the pandemic, so I'd have liked to have seen where handover times were, say, 2019. I don't know if that had been possible at all. To kind of relate how much of this has been a problem caused, not necessarily by the pandemic directly, but various offshoots of that. Because I think you talked there about people seeing 999 as a catch-all, and I think that's been a response to various things happening in the pandemic that aren't directly related to COVID-19.
Yeah, well, we can get you the. I haven't got the numbers in kind of to hand, but they've effectively doubled if you looked at it at a trust law. And Dave might want to comment in terms of the experience locally. But we know that those hospitals, fortunately, L&D isn't one of those, but those hospitals which were struggling pre-COVID are struggling worse following COVID. So it's been an exacerbation of existing challenges and issues that we've seen. But I don't know, Dave, if you want to anything about locally for L&D.
So from the L&D's point of view, I've worked for this area now for 26 years. Pre-pandemic, I would say that the L&D could pretty much cope with everything that came in. Our benchmark was always, if the L&D fell over, then we know we're in trouble, because it was like one of those hospitals that never ever would struggle. Unfortunately, as we were saying, now post-pandemic, L&D is one of those hospitals that is now struggling. Why that is really hard to understand, because like I say, I've worked many years and I can't figure that one out at the moment. I think a lot of it is support services pre-hospital that we're struggling with. People are perhaps not being able to access GP services adequately. 111 services are putting a lot of pressure on the ambulance service. So I think a lot of that comes from that, and people, I think a lot of the public are perhaps losing confidence in those support services. So the one-stop phone call to us is their point of call to actually help them, support them, and perhaps guide them in where they need to go. And I think that's been the issue. And then if we can't access those, unfortunately, one of the only places is the hospital, and that's just blocking, the services. So I think that's been one of the problems that's happened post-pandemic that I've noticed.
Yep. Yeah.
Sorry, I'll add to that, because Healthwatch did some inquiry at L&D, and a lot of the patients that were actually in A&E didn't actually need to be there. They needed a GP and couldn't get their GP, and so that is all building up, isn't it? Yeah.
Thank you. Actually, I've got a follow-on question from that. You were talking, Tom, you were talking about rerouting and diverting calls that you get. Is that like a whole new switchboard system, or?
Fortunately not. So we maintain what in technical terms is called the stack. So when you call 999, a call handler will take your call and will guide you through a set of scripted questions, and there's an algorithm that sits behind that that script, which is what generates the code. So a C1, C2, C3, but there's a lot more clinical information captured through that process. That patient then gets moved into what's called the stack, which is effectively all the patients that are waiting who are available either for dispatch or for some form of additional clinical assessment by one of our clinicians in control. That's how it currently works. Effectively, what we'll be doing is allowing community services and other partners access to that existing list of patients through our systems. And what we are just finalising with them at the moment is which codes are most appropriate for them, so that we'd never lose them. So they stay on our CAD and still stay on our systems, but effectively, rather than a manual referral having to be made, which is how it currently works. So what would happen at the moment is a clinician might review a patient on the stack. They go, oh, yes, we think they might be suitable for this community service, and then have to make a referral by email, by phone, by various mechanisms to that service, who then has to respond and say, yes, we'll take that patient off you. We'll automate that manual process in effect. And so it should be much faster and allow it to work much slicker than the current system, because we're just limited by processing time at this moment in time. Does that make sense?
It does. Has it been? Have you tested it? I mean, are there safeguards in place to make sure that people are directed to the correct provider?
Yes. So we're testing it throughout October, and with the rollout going live in November fully. But what we will always do is, as I said, the patient will always stay on our system until they have been seen and appropriately dealt with by that service. And so if for whatever reason, say a service goes out to somebody and they still need an ambulance, there'll be the mechanism to get them that ambulance if that's what's needed.
Okay, thank you. Got a question on paragraph 14. I think it's probably a similar sort of question. You're talking about working with systems partners, and there's some detail about working with the community service providers. Do you have any? What sort of work are you doing with other systems partners? I mean, Dave was talking about the L&D. What sort of work are you doing with the L&D to try and resolve the issues there?
So I think we've got what we have a halo in place. So we have like a hospital ambulance liaison officer in place to assist with crews coming in, looking at if it's appropriate for them to come in, or so they would look at the stack, as Tom was saying, to see whether or not they do need to come to the hospital, or whether we can divert them, or whether they can stay at home. So we are continually monitoring that, and we are sometimes having reviews where, say, myself would perhaps go into the hospital just to see what is coming in, to see whether and why it's coming in, and then decide, what's been the breakdown of the pathway for them to come to hospital, and see if we can address that. So we are continually trying to work with the hospital, because we have a really good relationship with the hospital. So we are trying to work with that to try and find different pathways, and what is the cause of these breakdown in pathways. I don't know if you want to add anything to that, Tom.
The other thing that we're exploring, I think we've got a frailty line here, haven't we?
Yep.
Yeah. So the other thing, so working with individual specialties. So for instance, so for frailty services, so older frail people, actually the ability for our people when they're with a patient to be able to call into a consultant and say, this is Mrs. Jones, this is the presenting condition, and have a conversation with the concerned about whether bringing them into hospital is the appropriate thing to do, or actually there might be an alternative way of managing that individual. And we're keen to look at continuing to do that for a number of different specialties, because it's clearly worked in a number of cases, and being able to get our crews more expert clinical advice when they're with a patient, I think would be incredibly valuable to them. So we're exploring a number of other specialties like cardiology, respiratory, mental health, and how we can set that up. What's likely to happen, and probably one of the benefits of us operating at a regional level, is where one hospital doesn't necessarily have the staff to be able to man something like that 24/7, is actually getting multiple hospitals and multiple providers working together. So actually, can we across the region provide a consistent level of service and a reliable level of service? Because what's absolutely critical is you need to know that if you're out with a patient, if you're going to call a number, someone's going to pick up and give you the advice and support you need. You can't be unreliable. It's got to be, it's got to work each and every time. So we're looking at building on models like that.
Okay. I've got a question about the cultural side of things. Paragraph 20. You've got some percentages there. Do you have the absolute numbers?
I can get you them. In terms of the bullying and harassment survey, so we've undertaken our second bullying and harassment survey. So the first one of those was undertaken, I think, last summer, and we completed another one in the spring of this year. So in terms of bullying and harassment from managers, I believe that the reported level was around 7% when in the last report, and that's come down to around about 2%. In terms of sexual harassment, that's come down from, I believe it was something in the 30s, it was 30 or 40 individuals reporting it. That's down to, I think, 5 or 6 in the last report. And similarly in terms of the sexual harassment. So it's still one case is one case too many. That is absolutely clear. However, I think what we're able to do now, or increasingly able to do, is start to pinpoint the areas of concern and look at putting in some dedicated, focused time and intervention into those teams and areas where it does appear that there's ongoing chronic problems that need to be dealt with.
Yeah, absolutely. Obviously, one case is one, as you say, one case is one case too many. It's just, I don't, just not quite sure how to, does seem very, what's the way? It's obviously terrible that you do have this incidence of sexual harassment and other bullying. It's good to see that the direction of travel is in the right way. It's just, I think, just trying to understand that you say there's still 4 or 5 cases. What will happen to those people concerned? Is there criminal behaviour involved here, or?
So what we will do is, the survey is anonymous, this particular survey, but the work that we've been doing has been, how do we strengthen our systems and processes so people feel able to speak up, and B, then we've got the backup in order to be able to take through a disciplinary process or whatever process we need to take somebody through. If it is a matter which is criminal or against the law, we will work with the police on that. And we do work with the police on that. If it's a matter where the behaviour is unacceptable and not consistent with our values as an organisation, we'll take action up to and including dismissal. And we have done that over the course of the past year. And I think by doing things like that, that is enabling people to feel more able to speak up about their concerns, and so they can be addressed appropriately. A big area of ongoing work and training that we're doing for our people is around the appropriate use of social media within the workplace. And speaking to other ambulance services and other blue light partners like the police, it is just to appear to be a common theme in terms of misuse of social media within the workplace. And so we're doing a lot of training and support for all of our people around appropriate use of social media. And secondly, also a lot of work around where we have issues raised around the inappropriate use of social media, taking action in those instances. So there's been quite a big intervention recently in Essex to address a group that was misusing social media. The last thing that we need to do is we need to do more to support people like Dave. So what is absolutely critical is that we need to make sure that our frontline leaders are appropriately supported and have the time to look after their people. So what Dave may tell you is that currently we put an awful lot on the shoulders of people like Dave, both to look after their teams, to manage their local station, to be able to respond clinically to some of the most serious clinical incidents that we have out in the community. And so we are doing some engagement work at the moment to say, well, actually, how do we make that role more sustainable? Both so we don't lose people like Dave, but secondly, also that actually people have got the time to appropriately look after their people and address these sort of issues, at the bud, before they become a much more significant pattern of behaviour. So that's, I think, our way towards sustainability for the service as we move forwards.
Yeah, thank you. I'm just going to come in on what Tom was saying there. So one of our biggest issues as a responding manager and a responding leader is that sometimes we're not there, and because we're out on jobs and we have a certain level of response that we have. So when it becomes increasingly busy, sometimes our levels. So at the moment, a majority of the time we're what's called level 0. So we would only attend serious incidents, cardiac arrests, and incidents that require a manager response. Sometimes when it gets busy, our levels increase. Will go up to level 1. So that means that we would be able to go out to other jobs as well. So we raised that, and we've raised that a number of times with Tom and the exec team, and I'd say, look, that is all well and good, and we can go and respond to another job, but when staff are coming to us to see where we are for help and to create that safe environment, we're not there because we're out responding to jobs that maybe sometimes we don't need to go to, and we just get dragged into that whole job situation. So I think Tom's made a really good effort, and the exec team, to actually try and leave us at a level where staff can still come and see us, and we're visible, and we're there, and we're given the time to stand down, we're given the time to talk to staff. And I think staff, that's where the improvement is coming, because staff are able to come to us. We give them the time to talk where we haven't had that before. We've got certain support groups. We've got the freedom to speak up, which is very valuable to us, and that hasn't been we've never had that before. For years I've been in the trust, we've never had anything like this. So for us, that's a real support from a manager's point of view, because sometimes there are situations that occur that even for us it's quite difficult to deal with, but we have that backing and support from Tom and the exec team and elements that are put in place. And I'm not just bigging you up, so that's what's happened in the the last little time, and that's really helped us. So I think and maybe that's why there's been a spike of incidents, because staff are feeling that safe environment to come and speak to us. They feel they can trust us now, where that trust wasn't there before. So I feel they can trust us, they can come to us, and then we can raise what needs to be done, and then they feel appropriately these are now being dealt with. And as Tom was saying, that visibly staff are seeing that this is being dealt with and it's not acceptable. So I think that's a massive change that's been happening. And Tom's been driving that, so that's a massive change that's been happening.
Thank you. It's good to see that you recognise that it's a whole cultural thing from the top down, from management down. So I mean, you're also talking about there's a number of vacancies. Is this whole thing affecting performance and affecting staff recruitment and retention?
So obviously the culture of the organisation is definitely a factor in terms of why people may not choose or have chosen in the past to leave the service and go elsewhere. And that's why we have to change it, partly, is to address that. I think there's some other really important things that we have to and are working on addressing. So the first of those is how do we make the job sustainable? So and enjoyable for our people. So people who sign up to be paramedics or technicians, they want to be working out in their local communities and looking after their local communities. Where they spend hours sitting outside a hospital looking after a patient, that isn't what they signed up to do. And so that it's a really important. Obviously, there's a demand pressure and all the rest of it and the performance impact it has, but it also has a real human impact. And then people will choose to go and do other things. So there's definitely a factor there. The other thing that we need to address is that people, the way in which we structure roles within the service is kind of based on historic patterns and behaviours. And what we see is many people choosing to leave the service because they've got additional caring responsibilities or other reasons why they aren't able to complete a kind of standard shift pattern. So we've got to think, and I think that's a societal kind of change as well. So we've got to think through how can we become more flexible in terms of the way that and the opportunities that we provide to people to attract them into and to stay within our service, but also doing that alongside, obviously, we need to make sure that we've got a consistent level of provision 24/7 hours a day. So we are giving that some thought in terms of how do we provide a bit more flexibility around the way we roster and the way that we work to try and retain and attract people to the service. We have done, we're also working much more closely with our universities to look at bringing in more graduate paramedics. We're on track, I think, for having our most successful year for graduate paramedic recruitment that the Trust has ever seen, which is good. Because previously they've gone elsewhere, and we're looking at what we can do to also invest more generally in the ongoing education and clinical development of our people and create the time for that, because that's something that also has been sacrificed in recent years as a result of the operational pressures. And so, giving people flexibility, giving the people the ability to develop their skills and their clinical knowledge, I think, is also really important. So this is a 2-3 year kind of program of work to get there. It's unfortunately, I don't think we can't switch everything on overnight, but I think we are starting to take steps in the right direction to address a number of these issues.
Okay, thank you. If there's no more questions, yep, thanks both. Oh,
I just asked, do you do apprenticeships in the ambulance service?
Yeah, so we have both apprenticeships at a technician level within the service, and so well, this year it's around 75 because some of the issues that we had around apprenticeships last year, but we're looking to increase that to about 150 a year going into next year. And also we have an apprenticeship pathway which takes you from technician through to paramedic as well, that we're looking to expand. So and the interesting thing actually about the ambulance sector is that we have a really significant number of learners. So although you do have graduate paramedics, actually a lot of people within the service come in through something like an apprenticeship scheme or development scheme and kind of build their career through their time. And the reason for the video actually that Dave and Joe did was actually it was the first International Paramedics Day, I think, wasn't it? And part of that day was to promote the ambulance service as a career opportunity for people, where you can come in at virtually any level actually, and then we can support you to progress over time. And we're really keen to look at what we can do working with local communities about, promoting that opportunity and talking to people about that opportunity, because I think people think, oh well, I have to go to university and that's the only way I'm going to get to work. And that's university is not the right thing for me. Actually, there's plenty of other options that people have got if they're interested in a career with the service.
Okay, thanks both. Appreciate you coming along tonight because I'm sure you're both very busy. I think we have a video.
Before we start, would it be worth Dave just saying a few words about it?
Yep, sure.
So I'll just give you just a briefing of what happened, if that's okay, Chair. We was asked to do the first ever International Paramedics Day, which was on the 8th of July. And we was asked to promote that because it's never been done before. It's never been recognised, the work that we do. So we was asked to do it from the trust to say, look, you know, and everyone would do like a bit of a vlog or a blog just to do it. So we did it. But unfortunately, it went a bit wrong. So we were supposed to ask each other just a question of what it's like to be a paramedic, and that was the promotion of what we was going to do. And me trying to be serious, Joe, my colleague, trying to be serious, it just went wrong. But on the back of that, it went completely viral. It's hit every continent in the globe now. It's been recognised all around the world, and had this video not happened, I don't think International Paramedics Day would never really have taken off, because it's one of those things that people didn't know about. We've had messages from the war in Ukraine saying that, thank you for all you're doing. We've had people saying about, if the trust has leaders like these, then absolutely I'm going to go and work for them, because it just, this is what working is all about, and it just shows being human. That, and so it was one of those promotional things, and I think at the moment we're about between 20 and 30 million views. I think we are worldwide, but like I say, this has hit every continent, and it just went mad. But in a real positive way. We've had no negative. I think Tom's obviously had messages and comments, and we've been interviewed from America to Australia to everywhere, and yeah, it was for what happened, the actual promotion side of it couldn't have been more positive, to actually, from a recruitment as well, and actually to join the ambulance service and get it recognised. So yeah, it was we did do it eventually, just to be clear, but yeah, it was this that went viral.
Thank you, Chair. Just a question regarding, the saying recruitment and all that stuff, apprenticeship. Can you tell us more in details? When is your recruitment day? It's once a year, or what is the method that people want to apply? How can they apply? Is any website or any address or any something like that?
So we routinely hold recruitment events over the course of the year. There's information on our website, but what I can do is if I perhaps send some details around to the committee in terms of any events which are coming up, how to find out more information, etc. If there's enough interest, we'd be delighted to go into local communities and to run a specific event. And so if that's something of interest to members, we'd be very keen to support that. So.
Just on the recruitment, so I spent about 12 months in recruitment, and I did various roadshows. I went to all the colleges, universities. I went on local radio, both, like Free Counties radio, but also went into local radio. So there was some Asian networks that I went into, because this is all inclusive of the community, and not many people realised how they could come in, how they could join, because it almost seemed like a very secret sector to get into the ambulance service, and that's how it was perceived. And when we went out there for that 12 months that I was doing it, people didn't realise how easily accessible it was, and what there was available to them. So I spent a really good 12 months doing that. I know it's difficult now, but that's and I literally had hundreds and hundreds and hundreds of applicants coming in then, because they didn't realise the opportunities that were available, and sometimes we have to do those drives, and we needed it at the time. So yeah, but as Tom was saying, it's just a routinely, the website shows it, but at that time I tried to reach out to every part of the community that I could, and I was literally bombarded with so many people that wanted to join because they didn't realise the accessibility of it.
Yeah, thank you very much. I like this. Yeah, thank you very much for this. And as you said, you're doing great job. And in terms of, if I ask you, can you email to the whole committee? So what we do as a councillors, we have WhatsApp groups, we have contact with the residents, so we can spread the word to our residents. And if you have any like flyer, something, leaflet on the website, or we can spread to the people. Yeah.
Yeah, we can definitely do that. And the other thing we can also send you some details about is for people who perhaps aren't looking for a full-time job with us, but are interested in getting involved in the ambulance services. We've got very active community first responder groups in Luton as well, who are also always looking for volunteers. And for some people, it's a good opportunity to almost try before you buy a little bit in terms of if you're potentially interested, but it would be a big change for you. So I'll also include details around our CFR recruitment because we're going to be running a further drive for that over the course of the autumn.
Thank you. Okay, I think we're ready for the video.
Welcome. Okay, hello everybody. Welcome to Luton Ambulance Station. My name is Dave Tamara. I'm a LOM at Luton and have been a paramedic or been in the ambulance service now for 26 years. And my colleague is. I'm so sorry. I can't do it. Welcome to Luton Ambulance Station. Good afternoon, everyone. My name is Dave Tamaro, paramedic at Luton, and I'm sitting here with Joe Cartwright, another paramedic from Luton. So we're here to talk about International Paramedic Day, which is on the 8th of July. Tell me, Joe, what does that mean to you? Sorry. Tell me, Joe, what's it like being a paramedic? No. Good afternoon, everyone. My name is Dave Tamaro. I'm a paramedic at Luton, and I'm sitting alongside my colleague, Joe Cartwright, another paramedic from Luton. And we're here to celebrate and actually recognise the first ever International Paramedics Day, which is on the 8th of July. Joe, tell me, how does it feel to be a paramedic? It feels really good to be a paramedic. I don't know why you saying that. I can't stop saying it feels good. I'm so sorry.
Okay, thanks both. Thank you. Sure.
Just basically some information. I'm Dalo Ward Councillor and I'm organizing for my residents at Dalo Festival in month of February, I think March, first week, something like that. And you have any responsible person, or you can, is yourself or somebody else, you can give me details so I can invite you as a crew there. So for the awareness of the young people, they can, with ambulance, and all that stuff, just for awareness and encourage our youth, and they can ask you questions, some information you can give them and all that stuff.
Yeah, no, definitely. If you can get the details over to us, and if I include our contact details on the information we circulate around to members, then yeah, let's get the details, and we'll make sure that we get some members of the team over to join. That'd be great.
Can I get your details so I can pop email to you?
Yeah.
Thank you.
Thank you. Okay. Yep. Thanks, Tom and Dave. Thank you. Go on to the item 11, the draft work programme. So for the 27th of October, we have primary care, GP access, resolutions, drug and alcohol treatment service, and are we confirmed for the modernising the inpatient mental health care programme?
We need to add the cancer screening, which has been postponed from today.
Does anyone have any comments on the work programme?
Needs assessment has been done. Finished. Oh, in the start. Okay, sorry. I missed that.
Yes, yeah.
Okay, thank you.
Okay, yeah, I think that's it.